Good morning. Is it morning? Yeah, thank you so much for that kind introduction, and thank you to the organizers for having us here. To the participants, for those who are not from Kenya, welcome. We hope that you enjoy the Kenyan hospitality. It shouldn't be all work and play. So I'll be making, it shouldn't be all work and no play. Yeah. I'll be making a presentation on how we adopted the WHO testing strategies in Kenya. And that's my outline. So we know this. I don't think I need to belabor on this, but the main essence of showing this slide is that in Kenya, we recognize testing as a key and critical entry point to not only identifying the HIV-infected persons in the population, but as a way of ensuring that for the negative, they continue being negative. So we have that very clearly elaborated in our Kenya AIDS strategic framework. Now, of course, to adopt the WHO testing guidelines, we had to adapt the guidelines. But WHO is always kind of following Kenya, so the story will be a bit mixed up because WHO came a bit later. We started a bit earlier in 2014, late 2013. And what made us start? Obviously, the last guidelines we had last been reviewed in 2009 to 2010. And then we have very dynamic HTS and laboratory technical working groups. So we had noticed there were several things we needed to sort out. The whole issue of linkage was still not coming out the way we wanted. The emphasis on correct results was still a problem. And then this whole issue of quality, as much as it was in the guidelines, it needed to really be broken down. So hence we started the whole process of reviewing our guidelines. So obviously it's a process. It had timelines, clear timelines. We thought we'd do this in 1 year. We ended up doing it in about 2 years. And it was a back and forth, and I'll be taking us through that. So under the planning bit, we obviously needed to get the mandate from the technical working group. One of the things we realized a long time ago is you need to have the lab team on the table right from the start when it comes to HIV testing. And I think in the last few months in this country, that has still recurred in our thoughts, and it's one of the things that we've learned as one of the take-home messages. And then we developed a secretariat that was going to we formed a secretariat that was just going to do work on the guidelines, and we had several subcommittees. We needed to involve program managers, specifically PMTCT team needed to be at the table. The care and treatment team needed to be at the table. And the legal team, because we were going to come up with crazy things like 15 years and above. Yet we know for us in Kenya, an adult is 18 years and above. So that was at the planning process. We then had a lot of consensus meetings on what would we like to see the guideline looking like, based on what we had seen from the field and what was coming out from literature. We had numerous writing workshops, both residential, non-residential, back and forth. And we had a lot of review, internal review, at technical working group level, at national MOH leadership level, and around that time is when we had the WHO testing guidelines being launched. So we also had to review and see, were we talking off what was in the guidelines? Thank God they had borrowed a Kenyan copy, so we were not so off. Then we had external reviewers. And in the reviewers, we had even representation from people living with HIV. We had key population representation. Obviously, we had the program reviewers. And again, I repeat the legal bit, because when you go start saying testing needs to be offered by a person who is non-lab, yet it is known to be a lab test, You need to have a basis for that, especially if you have very strong lab boards, registration boards like the ones we have in our country. So we had to get all that done, and also the age of consenting, and make sure that our guidelines speak to our HIV and AIDS Prevention Control Act. And then the MOH leadership review also needed to go through this. I see a lot of us in the room who were at that time, who we were with at that time, and the issues of even things like algorithm brought a problem. We spent several nights discussing about why we are dropping the tiebreaker. And one of the things we noted as a country is if you have data, in-country data, then it's easy to convince leadership. But if you just come and say WHO said, then the meetings can go on for quite some time. So thank God we had a lot of proficiency testing data that could show that, yes, indeed, we do have incorrect results out in the field, and hence we were able to indicate why we needed to adopt what WHO was saying. But then we adopted with our own special law, which I'll be showing. And so as part of the process, we had the launch, and then came the big animal, the dissemination. We had to have a very clear operational guideline. We noticed from last guidelines, it's very easy to have guidelines and say targeted testing. But when you go to talk to a healthcare worker, you need to break that down. You need to say exactly what you mean by targeted testing. So we developed operational guidelines, SOPs, and a dissemination plan, and put in how we're going to monitor what we're doing. We also realized we have to now revise every other thing, like the curriculum, the training curriculum. Thank God we were revising our mainstream HIV M&E tools, so we were able to incorporate all these retesting things in the tools. And then we are at that last bar where we've been now about 1 year plus 3 months of having the guidelines out there. But we are keenly following up, and there's still dissemination going on. We've disseminated to a majority of healthcare workers, but we still need to disseminate more. And the monitoring of the dissemination is really a mandate of the HTS and Lab Technical Working Group. We've realized WhatsApp is helping because we are connected to the county trainer TOTs who update us on the issues. Like for instance, what should a healthcare worker do when they get an inconclusive result? Those things, we think they're easy because they're in the guidelines, but a different kind of language is needed when you're talking to a healthcare worker. And then we are planning for service quality assessment to assess the uptake of the guidelines that we revised. So that was a dissemination plan. As I said, we've done a majority. We have a database. We now know who's offering testing in our country. One of the things we realized, a lot of the persons who are offering testing under the PMTCT are actually not really trained. So we are making making plans on how we can upgrade them so that they can at least have that formal HTS training. So our guidelines, I know I've talked about them, but this is how they look. We moved from the 3 C's to the 5 C's. We really outlined the roles of the national and the county levels as regards the HTS policy, given that we have devolved a lot. Health is now at the county level. Issues like storage of kits is at the county level. Some counties do not even see what HTS, they wonder what we're talking about when it comes to HIV testing, given that we have told them, we have tagged it to the target of how many people they need to identify towards 1990. Then we have defined pathways of referral very clearly. I talked about the tiebreaker issue. That was one of the things that we spent long nights really discussing should we or should we not drop. We've given explicit guidance on retesting for various subpopulations, put it in a table format. In our initial guidelines, the ones that we printed in 2015, we realized the way we had done it was not quite clear after we went out to train the healthcare workers. So in the reprint, we put it in a better way. So one of the things we also realized, when you print, don't print the whole bulk that you need. Because after you train is when you realize you may be speaking a language in the boardroom that's not really understood when you go out. So you have that opportunity to do some updating and now put it the way the frontline healthcare workers specified that they would like it to look like. That's the algorithm. I've put it there, not for you to like really understand, okay, it's like WHO, what is in WHO, but you see, it's pretty long. And I can tell you, even amongst us, the National HTS and Lab Technical Working Group, we took long to understand this algorithm, like what happens where, who tests where. Then we realized at some point we had said the retesting should happen at the comprehensive care clinic, which is the place where you refer all positives. Then we realized we had left out, how about the women who are identified as positive in ANC? Do you want them to start again looking for the CCC? The other thing with this algorithm, healthcare workers, especially the lay counselors, they feel like they are being tested.
Okay, 2 minutes.
So, yes. So they over-test because they're like, somebody else is going to test after me. So we've realized our commodities are running into very huge numbers. So there's lots of, the retesting is not even happening like 4 times. So that's one of the things we are trying to see how we can sort that out. So we are telling them to relax. It's just part of quality. Nobody is checking whether whether you're failing. But we have also now had an issue that there has been a case in Kwale where, because of identifying a client as positive, but later they are identified as negative, people are being taken to court. What do we have? I mean, and yet the act, the guidelines are all saying lay counselor, nurse should offer a test. But the lab board is saying, no, a HIV test is a lab test. You understand? So we go back to the drawing board, okay? So we are having a few issues under that algorithm. And then the whole testing to be offered to adolescents and the youth, but this one we haven't had problems with it. So 15 years is acceptable. Self-testing was in the previous guidelines. What we decided with these guidelines is to operationalize it. So we have developed operational guidelines for self-testing. We've decided no more pilotitis. In this country, we are going ahead with HIV self-testing because we know no matter how many times we test, there are people we just won't get. Like men, we will never get men through the way our healthcare system was designed. It was designed for children and women. So men, we need to look for a different way. Our current yield in 2016 was 1.7, and we are having to think through different mechanisms of increasing our yield. And then we emphasized on program integration and included early infant diagnosis in our testing guidelines. We realized people forget babies and say that's EID, but that's still testing and needs to fall under HTS. So in summary, the revision took a lengthy process, slightly under 2 years. Consensus building and inclusion of all stakeholders right from the start was important. And then the country needed to have data that could be used to back recommendations, because even when you go to disseminate to the healthcare workers in the field, they ask you why. Why are you just following WHO blindly? You need data. So the more we had the data, the more we are convinced, and the more we convince. And then we have a very clear implementation and monitoring plan for operationalizing the guidelines once we launched. So thank you so much. Acknowledgements to the HTS and Lab Technical Working Group. Maybe they can stand. This being our country, we are allowed 1 minute extra. to everyone else who has been involved in this process, and to our frontline workers and our Kenyans who still, despite all the stories we see in the newspaper, they still seek services in our healthcare facilities. Thank you.